Hello, I'm Professor Mark Creamer, Director of the Australian Centre for Posttraumatic Mental Health at the University of Melbourne. At some stage in their lives, most people will experience one or more very frightening or traumatic events. Thankfully, most will recover with the support of family members and friends, but some will go on to develop more serious mental health problems like Posttraumatic Stress Disorder or PTSD. The Australian guidelines for the treatment of adults with acute stress disorder and post-traumatic stress disorder outline the best approach to helping people recover from trauma. The guidelines were supported by the Australian government and they were developed in consultation with experts and people affected by trauma. The guidelines have been approved by the National Health and Medical Research Council and endorsed by the key professional associations, the Royal Australian College of GPs, the Royal Australian New Zealand College of Psychiatrists and the Australian Psychological Society. This DVD aims to help practitioners understand the practical applications of the guidelines to ensure that people affected by trauma get the best possible care. The goal is not to teach you the skills, but to make clear what the guidelines recommend. And I emphasise that these are recommendations. They're designed to inform clinical judgment, not to replace it. After watching the DVD, we hope that you'll have a better idea of the key points in managing patients following a recent trauma. We'll tell you about some tools you can use to screen for traumatic exposure and PTSD, and we'll give you a better understanding of best practice treatments for these problems. I hope you'll find this DVD useful.
When someone presents within the first week or so after a trauma, the guidelines recommend basic psychological first aid. Essentially, this means providing support, ensuring that the person's practical needs are met, and encouraging them to look after themselves and make use of the social support offered by family and friends. There are three key principles for helping someone at this early stage. Firstly, to monitor how they're going over the first few weeks. We call this watchful waiting. Secondly, to provide only as much assistance as is needed, with an emphasis on practical needs like safety. And finally, to encourage return to normal life and routine as soon as possible. We keep intervention to a minimum because most people will recover on their own, using their usual coping strategies and supports. Intervening more than is necessary could interfere with this natural recovery process. The idea of returning to normal routines at work or around the home is that it provides structure and purpose which will help the person to recover. People should be encouraged to return to normal activities as soon as possible as a way of helping them to feel better. But of course, they may need support from work, family and friends to help them to do this. The guidelines recommend against the routine use of psychological debriefing, which is requiring the person to talk through their experience and emotional reactions in a detailed and structured way. And that raises the question of whether people should be encouraged to talk about what happened. Everyone's different. Those who want to talk about their experience should be encouraged and supported in doing so. And those who don't want to talk about it shouldn't be pushed. It's important to remember that we're talking here about the general approach for people who've been through a traumatic event. As you'll see later on, the approach is different for people who have developed more serious problems like PTSD. There are a small number of indicators that are important to consider in your early assessment. The first of these is the person's presentation. Normal reactions to trauma can vary a lot. Most people are distressed in the immediate aftermath. So the presence of distress is not in itself cause for concern. We need to consider the severity of the distress, its course over time, and its impact on the person's functioning. If the distress is manageable and is reducing over time, there's probably no need for intervention. But if the distress is interfering with relationships, if it's preventing the person from carrying out their normal activities, or is escalating in severity, we wouldn't want to let it continue without some intervention. The second key indicator is the person's coping resources. Do they have resources at their disposal to help them cope, such as exercise, involvement in rewarding activities, breathing and relaxation strategies, as well as social supports and a safe environment? Good support from family and friends is very important in normal recovery. We also need to keep a lookout for ways of coping that are unhelpful, such as overuse of alcohol or drugs, keeping overly busy, withdrawing from others and from enjoyable activities, and taking unnecessary risks. Thirdly, we need to consider risk factors. Known risk factors for developing problems after trauma include the severity of the trauma. For example, the degree of life threat to self or others, how long it went on for, whether it was repeated, and whether it was interpersonal in nature. Other life stresses, either current or likely to be coming up in the near future, and a past history of trauma or previous psychiatric disorder. We'd also check on any current risk to self or others. All of these indicators should be used to guide decisions about whether to intervene, and if so, how best to do so. We'll now hear from John, who was in a serious car accident 7 days ago. Although he wasn't seriously injured, he thought he was going to die, and it was certainly traumatic for him. In fact, motor vehicle accidents are the most common cause of PTSD in Australia. John, can you tell me how things have been for you since the accident?
I just haven't been myself since the accident. I've been very irritable and moody. I'm still at work. I work as a mechanic. Okay. But I've been very snappy with my workmates, and I've started making mistakes. So far my boss hasn't said anything, and the others generally seem to be cutting me some slack because they know about the accident.
Okay. And how are things at home?
I'm grumpy at home. I don't want to talk to my wife about how I'm feeling and what happened because I don't want to upset her. She wants to talk about what happened, but I'm just not sure.
Okay. Are you sleeping okay?
My sleep is a bit of a problem. I've been waking up during the night and having bad dreams about the accident a few times in the last week.
Okay. Do you think much about the accident during the daytime?
I get very upset when I'm watching TV because there's so many shows, action movies and ads with car accidents in them. I find I've just been getting upset, so I haven't watched much TV in the last 3 to 4 days.
Right. Have there been any signs of improvement at all over the past few days?
I feel a bit better than what I did a couple of days after the accident. And the whiplash has also settled down a bit.
Okay.
I'm not driving yet. My wife has been driving me to work. I find it takes a lot of effort even to go as a passenger.
Right.
I'm pretty exhausted and stressed out by the time I get to work, and it's only a 15-minute drive.
Okay. Are you doing anything to look after yourself?
I walk after dinner.
Okay, good.
But I can't run as I usually would because of my neck.
Yeah.
I have a couple of beers when I get home from work just to calm me down a bit.
On the basis of what John is telling us, it seems that he's still quite distressed, although less than he was in the first couple of days after the accident. He's still working, but his job performance is less than ideal, and his wife has to drive him there. At home, he's coping, but irritable. In terms of coping strategies, it's good that John is going for a walk each night. As well as being enjoyable, walking uses up energy and will reduce John's level of arousal, feelings of being wound up. but we'd want to keep an eye on his alcohol use. A couple of beers most days, not necessarily a problem, but we need to check that John's not understating his consumption and that it doesn't start creeping up. We'd advise John to be cautious about using alcohol to help him cope and probably suggest keep it to a minimum. John's wife sounds as though she's supportive, but John isn't really using that support. He says he doesn't want to talk to her about the accident because he thinks it might upset her. This may be true, or it may be that John just doesn't want to talk about it himself. Either way, we wouldn't push John to talk about the accident if he doesn't want to, but we would encourage him to talk with his wife about how he's feeling and allow her to provide the emotional support that's so important at a time like this. We'd encourage him to keep going to work and perhaps planning ways he can get some time out for breaks during the day to keep it manageable. We'd also suggest he stay with household routine as much as possible, although perhaps postpone anything that's particularly stressful for a week or so, if that's feasible. We'd also advise John how to gradually start to drive again. For example, he might start by getting used to sitting in the driver's seat when the car is parked, and then work his way up to going for short drives around the neighbourhood. Medication is probably not required at this point, although we might consider short-term sleep medication to help him get a few good nights' sleep. If John had reported that his distress was still very severe or was escalating, then we might consider using sedating or calming medications. It's important to bear in mind, though, that medication of this nature, especially the benzodiazepines, don't treat the underlying condition, and longer-term use isn't recommended. Is there anything you wanted to ask me just about how things are going, or any comments you have about how John's been since the accident?
He's been really grumpy and really difficult to live with.
Right. If there's an opportunity for you to talk to family members at this stage, it's certainly worth doing. This allows you to reassure the family about normal reactions to trauma and reinforce the strategies to promote recovery that have been discussed with the patient. It's also helpful for family members to be aware that more help may be required if the person's distress doesn't seem to be settling, or if they're turning to unhelpful coping strategies such as alcohol. On the basis of John's presentation at this point, we'd probably make an appointment for him to come back in a week so we can monitor his recovery. Come and have a seat. A week later, John returns for his next appointment. So it's now 2 weeks after the accident.
Yeah.
We're looking for whether John's level of distress has abated or continued, whether he's using effective coping strategies or any problematic strategies that might be getting in the way of his recovery. We also want to see if he's been able to enlist support from family or friends. If we find that problems have persisted, we'd start to consider whether John has developed a mental health problem following the trauma, such as early signs of PTSD, adjustment disorder, anxiety, depression, or substance use. We'd also consider the possibility that there may have been a pre-existing condition that's been exacerbated by the trauma, or that memories of traumas from the past may have resurfaced. So, John, it's been a week since we last met. How have things been for you over that time?
Not much has changed. My sleep is still a bit of a problem. I haven't been having the bad dreams as much, but I am still having them. I've been waking up pretty frightened and just saturated with sweat. I'm still finding I've been getting upset watching TV shows with accidents in them.
Sure. How have things been at work?
My concentration at work still isn't good enough. I'm making errors. Nothing too major, but I've noticed that my workmates have been looking over my work afterwards in a way that they didn't do before. I find I've been getting startled and just generally feeling pretty edgy.
Okay. Are you driving now?
My wife is driving me to work.
Okay.
I just feel too nervous about it. My mates have been telling me that I should just put the accident behind me, but I just can't seem to get it out of my mind. I'm still having trouble talking to my wife about it.
Okay. Are you looking after yourself?
I'm still walking after work.
Okay, good.
Well, my wife and I went to the movies the other night. Yeah, that relaxed me a bit. Well, we walked because it's only a 15-minute walk down the road. I've been having about 2 to 3 beers almost every night just to calm me down a bit.
So it's 2 weeks after the accident, and it's the second time we've seen John. We'd hoped that his symptoms and problems would have settled down by now, but he's still clearly distressed by memories and nightmares of the accident, still avoids a range of activities related to the accident, like driving, and is generally hyper-aroused. He's using some coping strategies like walking and going to the movies, but these don't appear to be helping much. Although he's going out with his wife, John's still not talking to her about the accident or how he's coping, so he's not really using the social support that's available to him as much as we'd like to see. So at this point, we'd probably make the judgment that John's symptoms are not settling and he'll need some further assistance.
John spoke openly to the clinician about his traumatic event, but we need to be aware that many people who experience traumatic events do not report them to their health provider. Often they present to the GP or other health practitioner with non-specific health problems, and sometimes it takes a bit of detective work to uncover what's really going on.
Hi, Sarah, come through.
Thank you.
This is the third visit for Sarah, who's repeatedly presented with headaches, gastrointestinal problems, disturbed sleep, general relationship problems and work difficulties. These features may be indicators of a range of mental health problems, but they should also start us thinking about the possibility of an underlying traumatic stress condition. What do you do if you think the person's presenting problems might be due to a traumatic experience? Often clinicians are hesitant and apprehensive about directly asking the person if they've been through a traumatic experience. We know that this can be difficult, but might be the only way forward if the person is reluctant to raise it themselves. This is more likely for traumatic events such as sexual abuse or assault that tend to be associated with shame and stigma. In inquiring about prior trauma exposure, it may be useful to ask questions about life events around the time the symptoms started. For example, was there anything unusual, stressful, or particularly traumatic going on in your life around the time you first started having trouble sleeping? It may be also useful to ask questions about exposure to specific traumatic events, including those that are more difficult to talk about.
Sarah, have you ever experienced any particularly frightening or upsetting events?
What do you mean?
Well, for example, have you been in a serious car accident or been the victim of an assault or sexual assault?
Yes, I was raped by my ex-boyfriend 2 years ago.
Okay, perhaps we should talk about that.
In the brochure accompanying this DVD is a brief list of screening questions for exposure to potentially traumatic events. You may wish to read these out to your patients when checking for trauma exposure. Alternatively, as we saw in the example previously, you may initially pick out the ones you think most pertinent, perhaps asking the full list at a later time if it seems appropriate. When the person has told you about a traumatic event, you might want to consider, amongst other mental health problems, a diagnosis of PTSD. PTSD has 4 key symptom groups. These include the re-experiencing of the traumatic event, active attempts to avoid thoughts and reminders of the event, a sense of numbing, and an elevated level of arousal. In the re-experiencing symptoms, the person experiences distressing and intrusive thoughts about the trauma or nightmares about it, and is often distressed and upset by reminders of what happened. Distressing thoughts intrude into the person's mind with little prompting. The avoidance symptoms may be active avoidance, where the person will actively try and push thoughts and feelings out about what happened and stay away from reminders. For example, a motor vehicle accident survivor may stop driving and stay away from the suburb where the accident happened. The avoidance can also be what we call passive avoidance, where there is an involuntary shutdown of the person's emotional state. They feel numb and have difficulty experiencing positive feelings like love or happiness. The numbing offers some protection against feeling overwhelmed by distressing emotions, although it obviously starts to interfere with their relationships and their quality of life. The final group of symptoms are the hyperarousal symptoms. This is where the person feels keyed up or on edge and are on the lookout for further signs of danger. This heightened arousal is also commonly associated with sleep and concentration problems, irritability, and heightened startle response. For a full list of symptoms in PTSD, you may wish to consult the accompanying brochure. As in the case of Sarah, once the person has identified one or a number of exposures to potentially traumatic events, it's useful to screen for PTSD. A 4-item screen that was developed for use in primary care has been included in this brochure. The next clip demonstrates the use of this brief PTSD screen.
Sarah, traumatic experiences like the sexual assault that happened to you can lead to particular sorts of what we call post-traumatic mental health problems. I'd like to check with you whether you're having any of those sorts of problems. Is that okay?
Yeah, okay.
In the past month, have you had nightmares about it or thought about it when you didn't want to?
Yes, I have a lot of bad dreams, at least one a week, sometimes more.
Okay. Have you tried hard not to think about it or gone out of your way to avoid situations that reminded you of it?
Yes, and if it does come to mind, I try and push it away as quickly as I can. And I avoid people who know about it because I'm worried that they'll want to talk to me about it. And I haven't had a boyfriend since.
Okay. Have you been constantly on guard, watchful or easily startled?
Yes, I'm very jumpy if someone comes up behind me, and if I'm at a party, I find myself scanning the room for men that look dangerous.
Okay. Have you felt numb, detached from others or your activities or your surroundings?
No, not really.
Sarah has endorsed 3 of the 4 items and is highly likely to meet criteria for a diagnosis of PTSD. At this point, we suggest practitioners conduct a more thorough assessment. As part of that assessment, it may be useful for the person to complete a brief self-report questionnaire. The measure we recommend is the PTSD checklist, called the PCL for short. It's quick and simple to use and it's free. The brochure accompanying the DVD explains how to get a copy. Periodic use of the PCL can also be helpful in assessing changes in the person's PTSD symptoms over time. While the focus of the DVD is on PTSD, it's obviously important that we assess other mental health problems, either as comorbid to PTSD or as problems in their own right. These problems include depression, other anxiety disorders, and substance use problems. It's also important to assess general safety issues, social and vocational functioning, social supports, and physical health.
Effective management needs to focus on the whole person. We don't only think about their mental health problems, we also consider their broader psychosocial rehabilitation and role functioning. For the purposes of this DVD, however, we're mainly going to focus on treatments that address the symptoms of PTSD. We'll discuss the evidence-based psychological and pharmacological treatments for this condition. A key point here is that trauma-focused psychological treatment for PTSD, which we'll describe in a minute, has been found to be more effective than any pharmacological treatment. Medication can be a very useful adjunct to trauma-focused treatment, but it should not be used in place of it where psychological treatment is suitable and available. Having said that, the reality is that the only treatment most people with PTSD receive is pharmacological, and so we'll be talking further about those approaches a little later.
Essentially, trauma-focused therapy consists of 3 elements. The person is assisted in a controlled, safe and systematic manner to confront the memory of the event. The memory is worked through until it no longer evokes the same level of distress. This is known as imaginal exposure. Together with this, the person is assisted in systematically confronting situations, people and places that they may be avoiding due to their associations with the trauma. This is known as in vivo exposure. Finally, trauma-focused therapy also includes assisting the person address any unhelpful interpretations about the trauma and what it means about themselves, their relationship with others, and the world that might be interfering with their recovery. This is known as cognitive therapy. These interventions usually take the form of trauma-focused cognitive behaviour therapy, CBT, or eye movement desensitisation and reprocessing, EMDR, that's conducted in addition to in vivo exposure. Importantly, it's strongly recommended that practitioners seek training in trauma-focused treatment before providing it. Alternatively, referral to practitioners trained in this treatment is recommended. Although trauma-focused treatment is recommended, it's important to emphasise that this doesn't mean that you start your interventions with trauma-focused work. Routine clinical practice would embed the trauma-focused work in a treatment plan that includes stabilisation and engagement, providing education about responses to trauma and treatment options, general symptom management, and addressing issues of relationships and role functioning. These components of treatment are very important, and clinicians can do a great deal in these areas. Generally speaking, the trauma-focused phase of treatment would include about 8 to 12 sessions. Further sessions may be required where there are several problems that arise from multiple traumatic events, if the PTSD co-occurs with traumatic bereavement, or if the PTSD is chronic and associated with significant disability and comorbidity. The development of a robust therapeutic alliance may require extra time for people who have experienced prolonged or repeated traumatic exposure or have experienced an interpersonal trauma. For those of you who are going on to provide trauma-focused therapy, the guidelines provide more recommendations on how to conduct this intervention. It's important to carefully introduce trauma-focused treatment to the person, what it involves, and the rationale for treatment. Even if you're referring on, it's helpful to explain what the person might expect.
Sarah, from what you've told me, it sounds like you might be experiencing something we call Posttraumatic Stress Disorder, or PTSD. The most effective treatment for PTSD is what we call trauma-focused therapy. Would you be prepared to give it a try?
Well, I guess so. I'm willing to try anything that will help me to feel better. But what does it involve?
Well, the most important thing when getting help for PTSD is to target the memories or the events that are causing this stress. Treatments that help you to cope are helpful, but not as helpful as those that actually target the memories.
I'm not sure I could handle that. I can't bear to think about the rape, let alone talk about it.
It is difficult, but important to remember you'll be confronting the memory of the rape at your own pace, and importantly you'll be learning skills and strategies to help you manage the painful feelings before we deal with the memory.
If I do it, what exactly will happen in the sessions?
Well, trauma-focused treatment's got 3 main parts. The first part helps you to gradually face the memories. While we're doing that, you'll also be gradually facing situations and activities that you might be avoiding until they no longer upset you as much. And finally, you'll be exploring thoughts and beliefs about what happened that may be getting in the way of your recovery.
So how does the treatment work?
Traumatic events like the event that you've experienced can be so overwhelming that it's often very hard for the mind to make sense of it like we would for everyday events. Trauma-focused therapy is a way of working through the memory in a safe, gradual and supportive way. By digesting the memory in this way, we can store it then alongside other memories for everyday events. That's not to say that it won't be distressing to think about, but at least it won't be overwhelming. And when it feels okay to think about, then you won't spend so much time and emotional energy trying to avoid it, and you can get back to a normal life.
So how long does the treatment last?
Well, the part of treatment that we call trauma-focused lasts for between 8 and 12 sessions, although we can't say for sure. But importantly, we'd be spending some time helping you develop skills and strategies to deal with the painful feelings before we dealt with the memories. Would you be prepared to give it a try?
Okay, if it will help me.
Okay. There are 3 or 4 different trauma-focused therapies listed in the guidelines. If one form of these treatments fails to produce a sufficient response, we suggest you consider another. Where no trauma-focused psychological therapies are effective, available or acceptable to the person, consider non-trauma focused interventions such as anxiety management or pharmacotherapy.
There is a range of circumstances in which pharmacotherapy is indicated. These include where it helps the patient achieve the level of stabilisation required to be suitable for trauma-focused therapy, or where the patient is unwilling to engage in trauma-focused therapy, has not gained significant benefit from trauma-focused therapy, has high levels of dissociative symptoms likely to be exacerbated by therapy, or in situations where the first-line psychotherapy is unavailable. Unfortunately, there is no specific anti-PTSD medication. Where pharmacotherapy is considered, the best evidence is for the selective serotonin reuptake inhibitors as a class of medications. Existing evidence does not reliably distinguish a preferred SSRI in the treatment of PTSD. So, the SSRI that you are most comfortable prescribing would be appropriate as a first-line pharmacological intervention. Other newer antidepressants or tricyclic antidepressants would be considered as a second-line intervention. A third line of treatment may involve the use of older MAO inhibitor antidepressants, although these should preferably be prescribed by a psychiatrist, given their side effect profile and the complexity involved with their use. The safety concerns associated with overdose of tricyclic or MAO inhibitor antidepressants need to be considered in patients presenting risk of self-harm. Where symptoms have not responded to antidepressant treatment, control studies have demonstrated the potential benefits of adjunctive atypical antipsychotics. Again, these would preferably be prescribed by a psychiatrist given concern with potential side effects. When pharmacotherapy is required in the acute management of a patient with PTSD, sedating, calming or antidepressant medication may be used. The treatment goal in this setting is symptom relief. There is no evidence that any pharmacotherapy used in the acute situation can prevent subsequent PTSD. However, it is worth noting that long-term use of benzodiazepines is generally not recommended due to risk of dependency and the possibility that they may interfere with natural recovery processes. When using antidepressants, increase the dose if the patient is not responding, being mindful of side effects. When effective, provide a 12-month initial course of the medication. Stopping antidepressants should be via gradual weaning to reduce the likelihood of discontinuation symptoms and the risk of early relapse. To reiterate, only use pharmacotherapy as the first-line treatment if trauma-focused psychological therapy is not available. Pharmacotherapy should always be supported by optimal psychotherapy for the individual in their given circumstances.
In the case of Sarah, we talked about assessing and treating PTSD as a single diagnosis. More commonly though, patients with PTSD present with a range of associated problems. The most common of these are depression and substance use disorders. Let's take a look at how the guidelines recommend sequencing treatment for PTSD for someone with comorbid problems.
There are other problems associated with PTSD. So the question is, in what order should these disorders or problems be treated? Where PTSD is comorbid with depression, the guidelines recommend treating the PTSD first when depression is mild to moderate. This is because the depression will often improve as PTSD symptoms reduce. However, if the symptoms of depression are severe, then they should be treated first. This is to minimize the risk of suicide. It is also to improve the ability of the person to tolerate therapy and to increase their capacity to concentrate. If their depression is severe, they may even have difficulty getting into treatment. Stephen is a policeman who was recently assaulted after pulling someone over for a traffic offense. In the past, Stephen has been exposed to multiple traumatic events of varying severity over his policing career. This latest event exacerbated PTSD symptoms that had already been accumulating from his past exposures. We need to assess Stephen's depressive symptoms and decide how to treat him. Stephen, you mentioned being depressed. Can you tell me a bit more about that?
Yeah, look, I generally feel down and flat, and there's not much that interests or motivates me. Sometimes, though, when I get into something I really like to do, I like go fishing with a friend. I start to enjoy that after a while, but I wouldn't be the one organising it or going out on my own. Whereas in the past I'd be jumping at the opportunity.
Okay. What about at home? Would you find it hard to get going, or do you do things at home?
Yeah, I tend to do a few things around the house since I've been off work. Fix things here and there, tidy up a bit. But I find that I don't feel like doing much. I get tired quite easily.
Yeah. And is this the first time you felt like this?
No, it's happened before, about 5 years ago.
Right.
I went through this for a few months, but I came out of it somehow. I went on holidays with my wife and things at work got a bit better and things generally improved.
Okay. Yeah. Are there times when things are more difficult for you, where you find it difficult to cope with particular things?
The nightmares get the better of me, though when I've had a hard night, I'm really flat and exhausted the next day, and I generally feel much edgier.
Right. And is there times when things get so difficult you feel like ending it all?
Occasionally, I wonder whether life's worth living and whether I could beat this thing. Going back to the police work though, I'd find that pretty difficult right now. I just can't see myself going back. I just wonder what there is left for me after that. You know, it's who I am and what I do. The thoughts, they come and go, but they don't stay around too long. I just tend to tell myself, don't be stupid. Just, you can get through this. And then I just distract myself.
Given Stephen's presentation, the guidelines would recommend treating the PTSD first. Stephen's depression does not appear so severe that it would get in the way of the treatment for his PTSD. He's still able to concentrate sufficiently and get himself to treatment. There is no active suicidal intent. A particularly down day often follows on from trauma-related nightmares. So this is further indication that if we can treat his PTSD, we could expect improvement in his depression. We would probably not suggest that medication is required at this point, as his PTSD and depression may respond to psychological treatment. Although, if Stephen's symptoms weren't improving with the initial provision of psychological treatment, we would reconsider whether adjunctive pharmacotherapy would be helpful. If Stephen's depression was more severe, if he was having trouble getting out of bed most of the day, had difficulty maintaining attention in a session, or active suicidal intent, we would recommend treating the depression first. The other most common comorbidity to consider is substance abuse. The current recommendation is to treat both simultaneously. This is because the two conditions are likely to interact to maintain each other. When treating simultaneously, however, the substance use should be controlled before the trauma-focused component of PTSD treatment begins. There are three important indicators to be considered in terms of patient readiness for trauma-focused therapy. The first is that patient should be able to have at least 2 substance-free days per week. The second is that they can attend treatment sessions without being under the influence of the substances. Lastly, it is important that they can deal with general stressors, conflicts, and triggers without immediate recourse to substance use. The issue here is that substance use before or after trauma-focused sessions interferes with the kind of information or emotional processing that is required for the trauma-focused therapy to be effective. When people present with substance dependence, intoxication, or acute withdrawal, the substance use disorder should be treated first. Stephen, can you tell me a bit more about your drinking?
I have 8 to 10 beers a night. It depends, of course. I'd have more if I had a fight with my wife or had a particularly bad nightmare.
Right. And you're drinking every day?
Yeah.
How has that affected your home life, your ability to do the things you need to do?
Look, I let people down, and more than one occasion I've left my children at school. I forgot to pick them up after I've had a big night the night before.
Given the level of drinking that Stephen has described, we would not be looking to start trauma-focused therapy yet. He's drinking every day, clearly also drinking more in response to stressors and triggers. Here the guidelines would suggest that the PTSD and the alcohol problems can be treated at the same time. The PTSD treatment that we would recommend at this point includes education about PTSD, helping Steve to understand the range of triggers and trauma reminders that are exacerbating his condition, developing a treatment alliance, and developing symptom management strategies. Once he has demonstrated a capacity to have a few alcohol-free days and not drink in response to conflict and stressors, we would then start the trauma-focused phase. Given some of the drinking is part of an attempt to lessen the intrusive symptoms of PTSD, it is important to try and treat these symptoms with trauma-focused interventions at the first available opportunity. Otherwise, there is a risk that the PTSD symptoms will exacerbate the drinking. In other words, the risk in delaying trauma-focused treatment for too long is that Steve may not be able to sustain alcohol-free time because of the re-experiencing symptoms will increase. When Stephen's drinking is under control, we would reassess the PTSD and depression, and if appropriate, start the trauma-focused treatment.
In this DVD, we've attempted to describe the key points from the PTSD guidelines. We've talked about how we might assess and treat people with PTSD. If you would like any more detail about any of the issues we've raised here, you can download a copy of the guidelines from our website. The guidelines also include advice on applying these recommendations to specific populations, such as Aboriginal and Torres Strait Islanders and refugees and asylum seekers. We hope that this DVD has been helpful.